Hello, everyone, and welcome to another Unfiltered production with Cindy Krafft and Sherry Teague. And boy, yesterday was a big day. Like normal, at the end of the day, the 2022 final proposed rule was released, and I'm sure that everyone that's listening has read it from top to bottom, and all 528 pages of it. And I say that very sarcastically because actually nobody has read this top to bottom in a way that could be commented on succinctly. Is that fair to say, Cindy, that it's too soon to know the full impact of this?
Yeah, I mean, it's not light reading, but it takes a little bit of time to go through some of the nuances and to sort through. I think the comments that they make and their response to comments really can be insightful as well about their decisioning now and what they might be thinking about in the future.
One of the button items that was everybody was anticipating was value-based purchasing. And we've done a couple podcasts on value-based purchasing. There's a lot of information that's out in the ecosphere of home health on value-based purchasing. And I read last evening, actually at around 8 o'clock. This rule was released around 4:30, I think. And around 8 o'clock, I read the words from multiple consultants and entities that yay, value-based purchasing has been delayed. Is it delayed?
I'm hesitant to use that word, Cherry, because the actual language of the document refers to 2022 as a pre-implementation year. So some people may hear me say that and say, oh, that's just wordsmithing. It's a delay, get the party started. Yeah, not really. Because what they're saying is they heard the request for more time. And so what they've actually moved down the road is when the data will start to affect payment. So they're saying that the first year of information being collected to directly affect future payment will in fact be 2023. But what's interesting is the focus was on moving the year which the data will affect payment and not saying we're just going to not do anything with it all of 2022. We're just going to ignore all of it, which would lead me to believe that they are going to look at the data as if, if this was going to be the true baseline year, it's not going to be used to affect payment, but they still have the data. So I see it as an opportunity to say, okay, we've been given a bit of a grace period from a reimbursement standpoint, but we have got to use 2022 and should be on it already, making sure that our information is accurate, consistent, and defensible when it comes to any of those things that are being measured. And that leads me to, and I won't soapbox too long, Sherry, because I think we're going to need another unfiltered to talk about this one. Um, the OASIS questions that are going to make up 33% of the total combined number with respect to future payment implications comes from OASIS items that are, for the most part, going on 20 years old. And I've lost count of how many battles have gone on about these questions, and overwhelmingly they're related to function. And I still want to pull my hair out over but the patient lives alone, or they told me they can do it, or the nurses don't want to get them up to do anything, or the therapists score them all. The other thing in the final rule, Sherry, was OASIS E is January 1, 2023. The same time we officially start getting data analyzed with respect to this value-based purchasing business. So yeah, woohoo, it got moved over, means those two things are going to start concurrently. And that also means we have got to put to bed, in my opinion, forever, the old questions in terms of getting accurate information. We do outsource coding and OASIS reviews here at Cornetti and Krafft, and it is still the number one thing that people are spending time on is providing corrections and feedback around these functionally related questions. That's the number one area our folks are dealing with. It's the number one thing we're seeing clinicians make mistakes on. And we have got to put that to bed and be able to move on to be ready to deal with the new items that are in OASIS E. Yes, those other items are going to stay there because anything that affects PDGM, affects value-based purchasing calculations, those questions won't change, but they'll be in there with other new stuff. So we're going to have to make sure we keep our eye on all of this. And anytime anybody uses the word delay, Sherry, it's never in isolation. It's just kicking a can that tends to hit other cans that were down the road for us anyway.
And that brings us right into Oasis E, because there is a lot in this final rule about Oasis E, and there were obviously a lot of comments that were made about Oasis E. So what is the final implementation date that we know of right this moment? When will Oasis E begin?
January 1, 2023. The proposed rule wanted to disconnect any further delays from the public health emergency, and that is exactly what they've done. And people would say, well, why? Why can't, I mean, we're still dealing with the pandemic. Many comments were, can't this just continue to be delayed? But we have to understand that Oasis, whatever version we are currently dealing with, is a multitasker. It does a lot of things simultaneously. And there are elements, particularly around cross-setting measures and future iterations of value calculation, things called spades, which is a topic for another day. Those items, due to a wide variety of other reasons, need to become activated in home care. So we have to get the updated Oasis E and get out of the gate with some of these new items, because they are going to be important data collection pieces going forward.
So you guys heard it here. January 1st, 2023, the new Oasis E data set will be implemented. Now, that brings us into some interesting timing. So starting in January 2022, there's going to be some pre-implementation data collection by CMS regarding home health value-based purchasing. At the same time, a year from that, we are going to be starting new Oasis E. So they're going to be starting to collect actual data for value-based purchasing in 2023, correct?
Correct.
And that data will impact payments starting in 2025. So we have two huge things that are going to be starting in a little over 14 months, or a little under 14 months. And that's a, depending on the size of your agency, that does not give you a whole lot of preparation time to get ready. And they did state in the final rule that the Oasis E draft, the draft that will be coming for sure sometime in January. Usually it's going to be late January. Typically it's the last week of January, correct, Cindy?
Yep, they seem to typically they favor the end of the month.
And
But
it's late in the
we usually
afternoon.
get the final rule in October, and
Yeah,
it came in late, and it came in, but usually at the end of the day, like you said. So
yeah, yeah.
January at some
Usually at
point,
the end of a day on a Friday, we'll get that Oasis E draft. Is that the final
typically.
draft, Cindy?
Well, it's interesting because it came out in draft form before and then kind of got lost in the shuffle of everything else. And then it got delayed and it got backburnered. So I think it's an opportunity to put it back in front of the industry with, okay, now we know for sure what we're going to move ahead with. Here's your chance to look at it. I think it's important to look at it, to comment to things, but as I said a moment ago, we have to understand that the questions that affect payment, the questions that are used in calculations, the likelihood of us getting any sort of, hey, we don't want that question anymore, or can you fix the, grooming answers and give us, 6 instead of 4, high likelihood that is not going to happen. This is really going to be more of thoughts and feedback on the newer questions, and be able to try to proactively address any concerns. But we know that that's really going to be a tight timeline with respect to, now you've opened that up in draft. If you're going to have any feedback, then we have to wait for the final of the final of the final to make sure that we're educating appropriately on the real information that goes into play January 2023. But that's why I'm going to say it again, and I'm going to probably say it so many times over the next less than 14 months. Sure, they're going to get sick of it. That absolutely means old school Oasis items that you can look at an Oasis E now. You're going to know exactly which ones are carrying over. We need to put an end to the debate about accuracy, the resources consumed, trying to make corrections 500 times for the same problem, clinicians being aggravated because they keep getting their stuff returned for corrections, reviewers being aggravated because they make the same corrections. I mean, we are not going to have time to carry that old baggage into Oasis E.
No, particularly with the timelines and the association that it's going to have with home health value-based purchasing. And I just want to mention this, this looks like a good time to mention this, that between now and 2025, we have 3 more proposed rules that have the opportunity for comments. And just to let you know, it is our understanding that CMS must address all comments that come in about proposed rules when they start. However, if nobody comments, then they have nothing to address. So, I'll start my campaign now, Cindy, way early before the proposed rule for 2022 comes out in what, September? Usually August,
Well, it would be
somewhere in there.
2023. The one we
Yeah,
just have
2020.
is for
Yeah, the
2022.
proposed rule for 2023 comes out sometime in the summer, and they give you 60 days to comment. So make sure that you get your things in line so that you have things to say about value-based purchasing, because this conversation is going to be ongoing. It is not going to look like in 2025 like it looks like now, as we go through and we work out the kinks of it. And they have given us the years to prepare, a year to prepare. So the time to start is now. There's a couple of other things that I think that people need to read the exact language on that were in the proposed rule. Number one is home health aide supervision. I don't want to go into the actual details of that in this podcast, because I really feel very strongly that every agency needs to look at their policy and look at their home health aide supervision policy and make sure that it matches up, because there are distinct requirements in the proposed rule about how often the home health aide should be supervised, not just supervised by a clinician while they're there on their visit, but supervised directly while they're performing their tasks. So yes, definitely take a moment and look at that. Can you talk to me a little bit about OT? OT is very confusing to me still, and I don't think that this this final rule made it any clearer for me. Did it clarify for you what OT can and cannot do with the OASIS?
Well, I think what they were trying to do was address the issue of OTs doing admissions from the context of the actual conditions of participation. It got confusing because we're still currently under waivers, and under the waivers from the public health emergency, we know that even if nursing is ordered, therapy can perform the admission. But we have to remember it's a waiver. It's not a permanent change, and it was not converted to a permanent change in the final rule, although people asked for that. They specifically said what we've been told for years. To change that would literally take an act of Congress. So the waiver is in place temporarily, but that part can't be made permanent. And so what they were trying to clarify is that if nursing is ordered, then nursing is the one, aside from the waiver situation, nursing is the service that needs to do the admission and the comprehensive assessment.
And let me
That
jump
rule
in,
is
let me jump in
unchanged.
real quick. Let me jump in real quick, Cindy. That rule's unchanged, and we are still in the public health emergency technically until the beginning of the year.
Correct.
October 18th, the Department of Health and Human Services Secretary extended the public health emergency through this last quarter. So be really clear that the waivers that were in place for the pandemic are still in place at least until January. But starting in January, we'll have to see what's going on with the pandemic and the public health emergency situation, right?
And I think that's what causes the confusion. What they were speaking to in the final rule was the actual regulation, not the waiver.
Gotcha.
So the waiver's still in place and we follow the waiver. What they were addressing is the people lobbying to make that change permanent.
Yep.
And so, as I said, it would literally take an act of Congress, so they can't change it. So they were reiterating that if nursing's ordered, they need to do the admission. However, what they did amend and make permanent was in the infamous therapy only admission. So if nursing is not ordered, if it's PT and OT, OT and speech, all three, any of the three could do that admission. So that's a positive thing. But back to the Act of Congress piece, OT, if that is the only thing ordered, still does not stand alone as a qualifying service. Back to the
At the start of
Act of
care.
Congress thing. Right.
At
They
the
cannot
Yeah.
do the start of care. They can recertify all by themselves for as long as it's medically necessary and the patient meets all criteria. They can be ongoing, but to open a case, OT still cannot do that alone. And the waiver didn't change that. Nothing about the current waiver said OT could stand alone and do admits. It was only about the timing and trying to give agencies greater flexibility in the middle of a pandemic. But keep in mind, again, what they're speaking to in the final rule is the actual regulation, not the current waiver situation. And that's why I think it's important, Sherry, and I want to reiterate, I think it's very easy to want, updates to be convenient, to say that, oh my gosh, it's 500 pages. I'll just wait till I get the email that says, here's the 5 things, or the article that says, here's what I need to know in like 3 paragraphs. I like summaries. I like cliff notes, but I think it's imperative that you actually read the regulation. I'm not saying it's fun reading, poolside reading, or sit by the fire, and it's not fun. But I think it's important to read it for yourself, because sometimes interpretations may have a specific slant to it, or maybe got to the gate too fast and missed some other pieces. So it's important to look at it yourself and to really make sure you understand what is included, what it actually says. And there may be portions where you say, oh, well, this whole part here is about hospice. Maybe I can just cut a big chunk of this reading out if I don't read the hospice stuff. You could make that argument to a point, but I would still encourage, if you have the time, to take a look at those kinds of sections as well and say, maybe that doesn't apply to me directly at the moment, but it gives us insight into what the rule makers are thinking. What are they considering? Because very often what starts out in one area ends up in some different variation in the other. So it's good to kind of peek over that fence, as it were, and say, what are they saying about this area, just in case. And I think by reading it, it gives us some insight into the decision making. And as soon as I was starting to read it last night, Sherry, I texted you about something that just jumped off the page at me. Is that in the final rule, they always give us, here's the comments about here's what we wanted to change, and then here's the comments, a summary of the comments, and then their final decision. Um, it struck me how many times the comments came from MedPAC, or at least that's who they were mentioning made comments, and then they would respond by thanking MedPAC for making comments, and then agreeing with MedPAC. No offense to the folks that make up MedPAC, but stuff that comes from MedPAC about home health usually is not what I would call positive. They're very much, we're overpaid, this needs to change. It usually is not for the better. So it was a little unnerving to see that. It speaks to the fact that we all need to be aware of what MedPAC is saying about our industry, because
That's a
clearly
whole other
CMS
podcast.
is.
Yeah,
Oh, yeah.
that's a whole other podcast to try and figure out who's on the MedPAC board. As D. Cornetti likes to say, that's like Skull and Bones. Is it Skull and Bones, the thing at Yale, the secret society at Yale? MedPAC's a bit of a secret society, and I just did a quick word search. MedPAC is mentioned 16 times in this document. So
Hmm.
there is no other entity that's mentioned that many times in this document. Just to close out the OT discussion, they did change the LUPA rate for OT, correct?
Yes.
And they
And honestly,
increased it.
yeah, they increased it. Honestly, I didn't even think about that. I'll be truthful.
Yeah.
It totally slipped my mind that the LUPA rates for the services that do admissions were adjusted upward by a percentage because of the fact that, doing an admission visit is longer and more resource consuming. And if you end up with a LUPA, you got to have a way to account for the agency cost. If OT is going to be capable of doing admissions, then the OT LUPA rate needs to be at the same percentage adjustment as PT. So hats off. This is why people need to read these things, and greater minds than mine need to think it through and send comments, because clearly somebody caught something CMS didn't, and ultimately they fixed it in the final version to make sure the LUPA rate reflects the additional cost of OTs doing admits.
And just to be clear, overall, supposedly there's a 3.2% increase overall in our reimbursement for home health, but that's based on a lot of math, a whole ton of
Well, and
math.
that math, I think, ends up at 2 point something in the end.
Yeah.
Because they make that's where you go, woo, and then you keep following the math. I'm like, wait a minute. So can you just bold out what it really is at the end, as opposed to the whole trail of that? But it was slightly higher than they said in the proposed rule, which is a nice thing. And that's where there was yet another MedPAC kind of booing any sort of increase to our industry. Thankfully, they didn't listen to MedPAC on that one.
Exactly.
But yeah, that kind of, it just struck me to see it mentioned that many times.
We were also heartened to find out how many times they mentioned maintenance in this bill. And this is a little bit longer podcast because it's a lot longer of a conversation with this whole discussion about home health value-based purchasing. Maintenance is not calculated appropriately. Stabilization is not calculated appropriately right now in home health value-based purchasing. But it was encouraging to see, and Cindy, if you want to talk about it a couple minutes, encouraging to see how many maintenance statements were made and stabilization statements were made in this bill.
Well, as someone who ever, all the way back to when they first started talking about value-based purchasing and outcome measures and being on several of those technical expert panels, my argument has been you can't just make it be that improvement is good and the other two are seen as not good, because stabilization can be a very positive outcome. Some of us that were the early adopters and the early commenters to anything related to this maintenance issue, very often the response was kind of dismissive. And it was very much, that was a Jimmo thing that has nothing to do with quality measures. And it always bothered me, but then this time, clearly, more people are recognizing this issue of stabilization. More people are commenting about it because now they came back and explained things a bit better. It wasn't the Jimmo was something else, has nothing to do with this. This was, we are trying to do that. They are trying to do that by looking at function in terms of composite scores with respect to value-based purchasing. And as I told you a few minutes ago, Sherry, what struck me is that they put in the final rule, hey, basically, it's more than therapy. This is not just maintenance therapy. Stabilization is a function of nursing as well. And I almost fell out my chair. I'm like, man, we've come a long way from the we're not really going to talk about this to we're trying to build this in, and it's not just therapy. It's interdisciplinary approach on stabilization of this individual, which I thought was a huge win. So some of us may look at it and say it's not measuring it the way I would measure it, but man, this has moved the needle on that conversation in a very real way. There's more work to do, as you said, Sherry, participating in other comment periods, but I saw that as a big shift toward meaningful conversation about the importance of stabilization as a positive patient outcome.
I will read this sentence. This sentence alone just made me get warm in all my cockles. We believe the proposed measure set encourages home health agencies to provide care that supports patients who wish to remain in their home, whether the patient's goal is functional independence, stabilization, or to prevent further decline. That's huge. That is huge.
Absolutely.
And so, folks, if you're not doing maintenance, you need to start doing maintenance. And I'm going to wrap it up there, Cindy, because this is a long podcast for us. But just to let everybody know, we will be doing some podcasts on more specifics of the pieces of the bill, and there's a ton more in this final rule, especially about infusion and other items. So please take a moment, like Cindy said, she encouraged you to read it. Mama said read it, so read it. That's all I'm going to say. Mama said read it. And read it in pieces or assign out pieces of it. Have your staff read chunks of it and have them present it to the rest of the staff. That's a great way to break it down and to get it into your policy language in your individual agencies. For now, we're going to let y'all go, and I want you to have a great day. Be safe out there and stay tuned for the next Unfiltered production. Thanks, Cindy.